Welcome to the new International HHT Guidelines educational series with tonight's topic, Pulmonary Avms. I am Nicole Schaefer, Director of Professional Medical Programs for Cure HHT and your moderator for the evening. Before we begin, I'd like to give you a little bit of background about the International HHT Guidelines. In 2008, Cure HHT hosted the first International HHT Guidelines Conference, which produced the first internationally recognized HHT guidelines in 2009. 10 years later, Cure HHT hosted the Christopher McMahon Memorial International HHT Guidelines Conference, which was only made possible by a very generous donation from the McMahon family. This event involved 12 months of literature review and topic team discussions with over 60 HHT patients and physicians from 15 countries. The results was the publication of the second International HHT Guidelines in the Annals of Medicine in September 2020. Cure HHT produced fact sheets for each one of these topic areas, along with guideline recommendations, all of which have been bound in this comprehensive guide to managing your HHT. We are providing the first copy of this guide complimentary to all HHT patients and providers. If you haven't received your copy yet but would like one, please complete the Join Us form on our website, and I will be posting that link in the Zoom chat. If you ever have any questions related to HHT, center referrals, or an event taking place, please contact the Cure HHT office either by email or phone. This information is also listed on our website. Now, I'd like to introduce our speakers. Dr. Miles Conrad is the co-director of the HHT Center of Excellence at the University of California, San Francisco. And Dr. Mollie Meek is a director at the University of Arkansas for Medical Sciences HHT Center of Excellence. And we also have Susie Sayers joining us tonight. She's an HHT patient that has been treated by Dr. Meek and has lung AVMs, and we'll talk to you to share her story about that tonight. So what we want to do is, while Dr. Meek turns on her video and begins to set up her slides for the evening, we're going to launch our first poll. And the question is, what is your family mutation? If you can take just a few minutes to answer this. Give it just another couple of seconds. So Dr. Meek, if you would want to talk to these results.
Okay. Hi, thanks for having me. Thanks, Nicole. Thanks, Cure HHT. I'm really excited to be talking to everybody today. I guess these results are not surprising that 40% of the patients that attend a pulmonary AVM conference are endoglin mutations. That would be about what I would expect. And then a fair number of people, it looks like 45% total, either don't know their test results or have not done genetic testing. So I think this is what I expected to see, and hopefully we'll be able to answer some more questions for you as the night goes on. Thanks, Nicole, for the poll.
Sure.
Okay, so I have no financial disclosures today, but I do have to explain to you that this slide deck, I'm going to use my pen and I'm going to try to provide you with some very basic information about what pulmonary AVMs are and how they impact you and the kind of screening tests we do. And so this is a total IT Zoom computer experiment for me. So if it works for you, then please tell me that it's working. And if it's a complete disaster, I need to know that too, so that I won't ever do it again in public. The objective of my 15 minutes here is to basically improve your understanding of pulmonary AVMs such that the guidelines make sense to you, so that when you go to a center and we say we need to do these 3 tests, it makes sense about why we're going to do an echo bubble or why we're going to skip straight to a chest CT or something like that. We're going to go over a few vocabulary words, and we're going to do some really basic anatomy and physiology. Anatomy is basically just the names of structures, and physiology is the function, how things work. Nothing too complicated, just hopefully to get you a clear understanding of how we work up pulmonary AVMs and how they impact your lives. I will not read the slide of definitions to you, so I'll give you a couple of seconds to read through this. The important things that I want you to remember from this slide are that arteries take blood away from the heart and veins bring blood back to the heart. There's lots of sort of thinking that arteries always have oxygenated blood or red blood and veins always have blue blood. That's not quite right. Arteries take blood away and veins bring blood back. And an AVM is just an abnormal connection of an artery to a vein. Now in Miles's presentation, he has some really beautiful pictures of AVMs. Mine are going to be scratch drawings, so prepare yourselves. So the first thing that's important to understand is how the blood flows through your heart and gets to your lungs. So because I'm a radiologist, we do things backwards. So this is the right side of your heart. And the right side of your heart is responsible for taking the blood from your body. So these are veins bringing blood back to your body. And then it's going to pump this blood to your lungs down here. And then your lungs are going to do all kinds of really good things. Uh-oh, my pen died. Your lungs are going to do really good things and bring the blood. They're going to put oxygen in the blood and bring it back to the left side of your heart. And the left side of your heart is responsible for taking all this oxygenated, healthy, good, rejuvenated blood and sending it back out to your body. Okay, so here's where the artery vein stuff gets tricky. These blood vessels here that are bringing the blood back to the right side of your heart, those are your veins. Inferior vena cava, superior vena cava, the veins in your arms. Those are going back to the right side of your heart. This blood vessel that comes out of your heart and goes to your lungs is called your pulmonary artery. And it's called an artery because it takes the blood away from your heart. The blood goes to your lungs, all kinds of good things happen. And then it goes back to the left side of your heart in a pulmonary vein. Because it's a vein, it's going to bring the blood back to your heart. This great big blood vessel that takes the blood out of your body is called your aorta. And it's a giant artery. The important thing to remember, which we'll talk about in a few minutes, is where your aorta goes first. And this is what impacts a lot of the symptoms and problems that patients have with pulmonary AVMs. So the first branches off of your aorta, the blood that comes out of your heart very first, goes a couple of important places. The first one is right back to your heart in your coronary arteries. So it's going to take the oxygen and give it back to your heart muscle. The next place is your brain. So the blood goes up to your brain to give your brain fresh sugar, fresh oxygen, all of that. And then it goes to the rest of your body, which we're going to say, not that it's not important, but it's further down the list. Heart and brain are the first 2 places the blood goes. So hopefully that makes some sense with my terrible drawing. Now we're going to talk about your lungs. So that was my art for your heart. Now this is going to be your art for your lungs. So I want you to imagine that your lungs are like a filter, like the filter in your car or the filter in your air conditioner or vacuum cleaner. Or another good analogy is a leaf. So the blood is going to come out of your heart and in to your lungs, and it's going to get pushed into these tiny blood vessels. And it gets tinier and tinier and tinier until literally the blood gets pushed in little marching single red blood cells through your lung tissue, just like you're pushing stuff through a filter. In a normal lung, this is what happens. And then as it's traveling through the lung tissue, it gets rid of waste, it picks up oxygen, and then it gets into bigger vessels and bigger vessels and bigger vessels, and it goes back to your heart. Okay? So normal lung is like a filter. The job of a normal lung is to add, sorry, my marker's delayed, add oxygen and remove waste. Okay, so things that are waste, carbon dioxide, which you blow out, and then all kinds of other little boogers and trash and things that are floating around in your lung, because remember, your lung is a filter. So it filters bubbles, it filters little tiny blood clots, it filters bacteria, all kinds of stuff get caught up in these little teeny tiny pieces of the filter as they move through. Okay. When you have a pulmonary AVM, you don't have that filter, and I'll show you sort of what that looks like in a couple of seconds. This is the simplest way that we check for pulmonary AVMs, and this is how we screen for pulmonary AVMs in children, and some places use this as their very first screening test in adults. So this is a pulse oximeter. They can look all different kinds of ways. This is an old one. It goes on your fingertip and it measures how much oxygen is in your blood, and that's this little piece over here. It should have a nice little waveform like this, and this is 99%, which is a great number. And then if we do an exercise test, then we might put you on a treadmill and run you, or when I see little kids in clinic, I run them around the hallway till they get tired and short of breath. And then we put the pulse ox back on their finger and see if all that work, all that extra pumping, all that extra blood moving through the lungs makes this number change, makes it drop, because it can't filter and put the oxygen in and get the carbon dioxide out as well. This is a picture of a child that's a patient of mine who came in with what's called clubbing. And clubbing is when the ends, you can kind of see on this picture, and Dr. Conrad has a great picture of this in his talk too, that's a little more artistic. The end of your finger gets kind of round and fat, and you see how his nails are blue. His pulse ox, when I saw him in clinic, was like 85%, which is way, way, way too low for a normal kid to be running around and playing sports and being physically active. So this is just one way that you can sort of see that you might have a problem with your lungs. Now, there are lots and lots of causes for clubbing. Lots of patients have clubbing and don't have pulmonary AVMs, but in an HHT patient, this kind of picture should certainly make you think about pulmonary AVMs. Okay, now we're going to go back to our leaf as our lung and talk about what an AVM looks like. So if the blood is coming out of the lungs, I don't want yellow, sorry, I want blue. If the blood's coming out of the lungs and it's going out into the vessels, now it's supposed to get pushed through all these little tiny places, but instead it goes through an AVM. So it goes right back to the heart. This place here is where the AVM is. So the blood that goes through this AVM circuit is the blood that's not going to get filtered. It's not going to get oxygenated. But all the rest of these blood vessels are normal over on this other side of the leaf or the lung. And so all the rest of that blood is going to be doing just fine and getting what it needs. So it depends on how many of these AVMs you have and how big this vessel is, right? You can imagine that the bigger this is, the bigger the shunt, the less oxygen you're going to get back to your lungs, okay? But if these are just, maybe you just have one or two little teeny tiny ones, then it may not impact you very much at all, and you may not notice any symptoms. You may not have any problems. One of the next tests that we do for pulmonary AVMs is called an echo bubble test. And remember, we talked about your lungs are going to filter things out. So this is an echo bubble, and I'll let you sort of watch this, and then I'll go through the anatomy here in a second. I'm going to see if I can pause it without flipping the slide to the next one. Okay, so in this picture, the ultrasound probe is kind of on the front of your chest underneath your breast on one side between your ribs, and you're looking kind of in at the point of your heart. This up here is your chest wall. So this piece down here, this is your right atrium. So this is going to be the veins. The blood's going to come in from the veins into your right atrium and through the right side of your heart, and then it's going to get pumped out to your lungs, and then it's going to come back into this side, which is going to be, this is your left side of your heart. Now, in a bubble study, we take some saline and mix up the bubbles, and we squirt them in your vein in your arm so it goes back to your heart. And now if you watch this picture, the bubbles are these kind of white gray things. As you see in this right here, there are no bubbles in this picture, but if you watch as the heartbeats go, you'll start to see little white dots in there. And those are dots that are getting through. Those are bubbles that are making it through the system. So you're going to start to see them here in a second. See all those little white sparkly things? Those are bubbles that did not get filtered out. So you know in this patient that there is a little AVM somewhere. It's not a huge AVM, because if it were a huge AVM, then all of those bubbles would go whoosh through and nothing would be getting filtered. Excuse me. But this patient just has a little AVM. And so we can count how many bubbles are in this picture and then decide whether or not a patient needs a chest CT or a more invasive picture of their lungs. And the reason we don't go straight to chest CT is because a chest CT is X-rays. And so we don't want to give people too many X-rays. In this picture, this is a chest CT, and this structure here are the pulmonary arteries. They come out of the left side of the chest and they bring the blood out into the leaf part. Now watch up here. I'm going to restart it. Watch up here. This is the right side because things are backwards in radiology. There you're going to see kind of a blob and a little coil. And I'll see if I can pause it right there. So those little bright white things, those are coils. I'm not going to go back far enough. It's not going to go. And this blob is the AVM. So this patient had coils a long, long time ago, and then started getting short of breath and noticed that she couldn't sing in church the way she used to sing. And so she came back to have an evaluation, and her AVM had reopened. So we had to go back and plug this up again. So here is another problem that you can have with your AVMs. And this is something that we see, sadly, a little too frequently. So let's say you go to the dentist and your very lovely dentist scrapes all of these gross boogers off your teeth, and then they get into your bloodstream just because that's the way it works in your mouth. So those little guys are floating around and they get into your vein and they go back to your heart and they get pumped out to your lung. And so here they are. Doot, doot, doot. Now, if they go into a normal blood vessel, they're going to get filtered out by your lung tissue. But if they go zipping through your pulmonary AVM, then they're going to go right back to the left side of your heart. And you'll remember that the first two places that the blood goes from the left side of your heart are your heart to give it oxygen and your brain. And so about 3 weeks after this patient got his teeth cleaned, he ended up in the emergency room with a seizure. And what you're looking at here is an MRI of the patient. This is the patient's nose. There's the right eye, the left eye, and then you can see this ring right there and right there. That's an abscess. It's just a little pocket of pus or infection that's deep inside this gentleman's brain. And unfortunately, he had to have a big surgery to get this scooped out. So that's just one of the reasons that we tell patients to take antibiotics before they go to the dentist. And one of the reasons that we like to fix pulmonary AVMs is because once this has happened, I can't undo this. We can clean it out, we can give you antibiotics, but but it's already happened. So it's sort of like this damage has been done. And that's what we really want to keep from happening to our patients, and why we do such rigorous screening tests. So this is my last slide, and then I'll hand it over to Miles, and at the end we can answer questions and all that. This is a picture of a pulmonary AVM, like a real angiogram of a pulmonary AVM. And so here's the left side of the heart. Here's the right side of the heart. And this tube right here, this thing, is a tube. So you come up from the groin, and you go out and into the lungs through the pulmonary artery. And so this is the pulmonary artery. And this thing down here, so this is the AVM. You can see it doesn't look like these little fine branches up here, and it doesn't look like a little filter or the leaf. It looks like a big squiggly mess. And so the blood just goes whoosh through here, and then it's going to go back to the heart, and it's going to come back here. And it's not going to get filtered, and it's not going to get oxygenated. And that's what causes a lot of the problems with HHT patients and pulmonary AVMs. So I hope that my terrible artwork provided some sort of basic understanding of how your heart works and how your lung works, so that you can understand all the guidelines and all the seemingly crazy things that we ask you to do. So thank you very much for your time.
Thank you so much, Mollie. So now while Dr. Conrad starts his slides, we will switch to the second poll, which is asking, where have your PAVMs been embolized? So if you could take a few minutes to help us answer this question. We'll just give it a few more seconds. And Dr. Conrad, if you'd like to talk to these results.
Hi, everyone. So yeah, what we're seeing here is that looks like there are many people out there that have not had their PAVMs embolized. Maybe they're being watched. Hopefully they're they're being watched, and we'll address the threshold at which to treat PAVMs based on the guidelines. So we can talk about that more. And many places are getting their PAVMs embolized at HHT centers of excellence, and also it looks like the minority are getting their centers or their PAVMs embolized outside of HHT centers. And it seems like probably you would think that the majority of people here in this taking the survey are tied into centers. So maybe there's a selection bias. I think that many times I meet patients that have had PAVMs embolized out in the community. And many people will get a PAVM embolized and maybe come to a center after that and then get the rest of their PAVMs embolized, or maybe they'll have a recurrence and they'll seek care at an HHT center. So that kind of makes sense. Well, thank you so much for including me in this really important presentation. And I'm really excited to talk to you about PAVMs and the updates that were included in the 2020 guidelines that were published in the Annals of Internal Medicine. So I am the co-director of the UCSF Center, and these are my disclosures. So I'm not going to go too much into what Mollie was talking about, but I just want to recap two or three different things before we go into my lecture, because it's important to understand some more detailed anatomy just to apply the guidelines. So this is normal lungs. These are normal lungs. This is a CAT scan. of the left side of the chest, just like Mollie was saying, when radiologists look at images, we flip them. And so this is actually the left side of the patient, as if a patient is standing in front of us. And normal pulmonary arteries get smaller and smaller and smaller, like branches of a tree, until finally they get smaller and smaller until they get to a capillary bed. And that capillary bed is really important, as Mollie was suggesting, because at that site is where you have oxygen exchange, and that's where we oxygenate our blood, and it comes back to the heart to get pumped out to the aorta, and also is important in that it filters clots and bacteria right here at that capillary bed. So that is critical when we think about um, emboli, or little clots, sometimes with bacteria, but usually just bland clot that breaks off from our veins in our legs or whatever. After we take a long car ride, we may have a little bit of a clot that breaks free. And in most patients, it will be caught in this filtering system. But in some people with a pulmonary AVM, a clot can squeeze its way through and go into bad places like the brain. So,
Excuse me, Miles.
yeah,
Are you able to convert your slideshow into full screen?
yes. Was that not working?
No, we were seeing speaker mode, and so the images were a little bit small.
Oh, I see. Is this still speaker mode?
It is.
Okay, let me see what I do about that. Is that
There
better?
you go. Yep, that's
Okay,
it.
great.
Thank you.
Sorry about that. Okay, so the important parts about the pulmonary AVM anatomy are that we have a feeding artery that goes into a sac, and typically there is one or more draining veins. So this is abbreviated as FA, the feeding artery. We measure the feeding artery right about here. We want to measure it as distal, or as far out as we can, right before the sac. And that is the key measurement that we use to apply the guidelines and to determine the threshold at which we should embolize a PAVM. So here is an example of a feeding artery that I've measured, and it's 5 millimeters. Some PAVMs have more than one feeding artery, and they supply the pulmonary AVM, which can look, doesn't have to be a sac. It can be kind of a nidus, and then it can drain through one or more veins. When you have more than one feeding artery, that is called a complex AVM, and this is what it looks like on a CAT scan, just a kind of a mess of different arteries. And these are obviously more difficult to treat because you have to embolize or plug up all the different arteries that feed it. The simple PAVMs, like this kind of case, is the kind of case that is just a little bit easier to manage. The consequences of PAVMs, as Mollie suggested, are severe in some patients if they are big. Many patients don't have any symptoms at all, and they just come in incidentally having discovered a PAVM. But this is a patient recently at our hospital that just 2 weeks ago that presented with a large PAVM with a feeding artery here and then a draining vein right here. And this is a different patient with a brain abscess related to a pulmonary AVM. Other things, hypoxia, huge problem particularly if you have big pulmonary AVMs or multiple PAVMs, then you may drop your oxygenation. If you have a pulse ox, you can go to altitude and you'll notice that perhaps your oxygenation will drop. And you may notice that after a PAVM is embolized or you have extensive embolizations, in the weeks that follow or the days that follow, your pulse oximetry will increase. So you'll have clear physiologic benefit from getting that embolization if they're big. Typically, small PAVMs won't really change your oxygenation much because the shunting is not enough. But yes, this is, Mollie was saying, talking about clubbing. This is clubbing. This happens. This is severe clubbing. One of the things I always like to ask patients is if their nails tend to grow in a curved way, and it's obvious when they come in to the exam room if that is the case. But sometimes you can ask them when they started to do that, and patients will say, "Oh, when I was an adolescent, I noticed that they started curving around if someone does have long nails. Importantly, migraines are also associated with PAVMs, and that's often not appreciated. So sometimes that is the main indicator that someone has an active PAVM because they have migraines, specifically migraines with aura. Those are the migraines that have little flickering lights or strange sensations prior to the migraine, but not as much the migraines without aura. And unfortunately, sometimes PAVMs that are quite large, like that one I showed you earlier, this one, they can rupture. And if they rupture, they can cause death or massive bleeding in the chest. And those are the feared complications that we really are concerned about, particularly with large AVMs and also in pregnancy. So let's talk about the HHT guidelines as they relate to PAVMs. So I have taken two sets of guidelines. There are only two sets. They come from 2009, but they were published in 2011 and 2020. And they are multiple guidelines. I picked out 8 guidelines as they pertain to pulmonary AVM. So if it's a PAVM in any way, guideline, but it's a pediatric, it's in the pediatric set, then I picked them out. If it's PAVMs within the pregnancy set of guidelines, I've picked them out. So I've distilled this down for you today to just think about PAVMs and the HHT guidelines. So let's get started. The first off is that Mollie and I were there at the guideline conference with a bunch of other wonderful colleagues. And this was made possible by the Christopher McMahon Memorial gift. And the best thing about these guidelines is that they are so accessible to all of you through an interactive website through hhtguidelines.org. So I'm going to take you through this, and hopefully it's not going to knock me off the, hopefully are you still seeing my screen? Hopefully you are. I would go to these guidelines anytime you want. You can go to these. They're all free. Let's go to the pulmonary AVM section. We see right here. So before you go to your HHT physician, you can think about your PAVMs and try to apply these guidelines, which are nice, interactive. They incorporate the 2009 and 2020 guidelines, and they give you a nice detailed background on each one. And I just really think this website is great. So let's go back to my presentation. So can you still see my presentation now that I've gotten out of that?
We can.
Good, great. All right. So there's 8 guidelines in 3 categories: screening for pulmonary AVMs, embolization in children, adults, and pregnant patients, prevention of sequelae in patients with pulmonary AVMs. Okay, let's get started. So I've put all these guidelines in this highlighted color. So if you ever see the highlighted color when I'm talking, that means I'm talking about a guideline. So the first guideline to think about is to screen patients with possible or confirmed HHT for pulmonary AVMs. What does that mean? What does the word possible mean or confirmed? Well, it turns out that that means 2 or more Carousel criteria. Carousel criteria are the criteria that we use to diagnose clinically HHT, or patients that are proven to be genetically positive with testing. So what are the Carousel criteria? The Carousel criteria are telangiectasias, nosebleeds, HHT confirmed in the family from a first-degree relative, and visceral AVM. So a pulmonary AVM, a brain AVM, liver AVM, those kinds of things. So if we see 2 or more, that's possible. If you have 3 or more, that's definite HHT by clinical criteria or the Carousel criteria. And then, of course, the genetic positive diagnosis. So if you have those, then we suggest, and the guidelines suggest, that you should be screened for PAVMs. What does that mean? That means that you get if you're an adult, you're most likely going to get a bubble echocardiogram that Mollie showed you to screen for shunting between the right side of the heart and the left side of the heart, and that happens in the lungs. That's called an extracardiac shunt, and that is very well seen with bubble echo. The reason we do that is because we want to prevent what are called paradoxical emboli. That's emboli that go between the right and left side of the circulation and can go from your vein, skip through that unfiltered lung and go up into your brain and cause a stroke or a brain abscess if a little bit of clot has bacteria on it. Some patients, clots don't go to the brain and they go to bones and other parts of the body and they can cause osteomyelitis. I've had a patient with hip infections and spinal osteomyelitis. That's bone infection is what that means. Or sometimes, rarely, they'll go through and slip into the coronary artery and actually cause a heart attack. So this is an example of a PAVM. You have a feeding artery. It gives you that tortuous characteristic and a big fat sac there. And this case, we measure the feeding artery. If I measure it here, it's 7.2 almost millimeters. This is the kind of thing that needs to be treated, and this patient had a brain abscess. The next guideline is to use transthoracic echo, or TTCE, transthoracic contrast echocardiography, to screen for PAVMs in adults. And this is using the bubble study that Mollie was talking about, where you look for bubbles. All this bright stuff on the right side of the heart are bubbles, and there's a few bubbles getting across to the left side of the heart. Now, that's not normal. They should, well, at least in this quantity, it's not normal. You should just, at the most, you should have a couple bubbles go across. But if you have a lot of bubbles go across, then it indicates that there is right to left shunting. Either that happens at the cardiac level through something like a patent foramen valve, or extracardiac shunting in the lungs due to a pulmonary AVM. We this is not included in the guidelines, but grading is really important for predicting the need for embolization. And this causes a lot of confusion sometimes in the even at the HHT centers or in the community, because certain places don't grade and certain places do. But the goal here is we want to prevent people from just getting radiated with a chest CT. And so we like this study. And it turns out that if you have just a few bubbles that go across, like less than 30, then we probably won't get a CT. But if you have more than 30 bubbles go across, then that is suggestive that you could have a pulmonary AVM that's big enough to treat. So in those cases, we'll go ahead and get a chest CT. And all these are papers that I'm showing you right now that just makes me look smart. But in reality, what they are things that show us that this has been validated multiple times, that grading is really important to distinguish pulmonary AVMs that should be treated and pulmonary AVMs that could be watched and maybe not necessarily need a CT. So our threshold to move from bubbles or move to CT is really if you have a grade 2 or higher echo, which means that you have more than 30 bubbles on the left side of your heart. Okay, so no need to worry about the details here, but just know that grading is something that is included in most HHT centers, but it's not yet included in the guidelines. So I wanted to point out what some things are there and some things are not there. Okay. We think that grading is important because it can predict if you have a pulmonary AVM that should be treated, and therefore you should possibly get a CT scan. Okay. And the size of pulmonary AVMs to treat are 2 to 3 millimeters of the feeding artery. So we look for that. If we see a positive bubble study, we'll grade it. If it's greater than 30 bubbles, we'll get a CT scan. And if that CT scan shows a feeding artery that's greater than 2 millimeters or 3 millimeters, depending on the opinion of everyone involved, then we'll go ahead and treat. Okay. The next guideline is to screen pulmonary AVMs in asymptomatic children with HHT. Now, this was a controversial thing, and this is new. This was not included in the 2009 guidelines, but it is in 2020. And there were some really important studies that came out, and I want to give props to Yale and WashU for publishing studies that show that pulmonary AVMs in children are unlikely to cause significant adverse events unless they are associated with hypoxia. If a child has a low oxygenation, meaning that they're below 93%, or if the pulmonary AVMs are on the periphery of the lung, then we might be more inclined to treat. But for the most part, kids just aren't the same as adults, probably because they don't have those clots that form in our legs like adults do as frequently. And they don't have infections in their body necessarily as frequently that, sometimes teeth cleaning and things like that can cause brain abscess and things like that. So it turns out that children are a little bit protected. And so there was this kind of debate about whether to screen children or not. And some centers were screening and some were not. And if you have a child that's symptomatic, then they're definitely getting tested for pulmonary AVMs, but they're not being screened because screening is for asymptomatic people, people that have zero symptoms at all. So this really is talking about people that have no symptoms at all, a child with no symptoms at all, should we screen them? So it turns out that the majority of children, as long as their oxygenation is normal or at least above 93%, they're probably going to be fine. But if they have a peripheral AVM, we may want to treat them, or if it's a large pulmonary AVM. Then Washington University published a series that looked at a bunch of children and found out that if you had a pulmonary AVM that was greater than 3 millimeters of the feeding artery, then they would suggest treating. And so we kind of merged all these studies together, and generally the threshold now for treating children is 3 millimeters, and in adults it's 2 to 3 millimeters. So they're close, but there was much discussion that went into whether you should screen asymptomatic children. Once they're diagnosed, we either treat them or we'll rescreen them at 5-year intervals and follow their pulmonary AVMs that way. There are 2 screening protocols in children. One is to use chest x-rays plus pulse ox, and another is to use bubble echoes. There's pros and cons of each. The benefit of the pulse ox plus the chest x-ray is that you're only going to find the PAVMs that are big enough to cause problems. The ones that have like big feeding arteries, 3 millimeters or more. And so if we use this, then we'll prevent patients from getting bubble echoes, and then those patients will often be positive and can go on to get CAT scans. And we just are trying to do this to, we want to avoid unnecessarily radiating children with a CT scan. So there's 2 protocols that you can use, the Dutch protocol or the bubble protocol, and you should talk to your center about which is right for you and which they prefer. The next is to embolize pulmonary AVMs in children that are large if they have a feeding artery that's greater than 3 millimeters or are associated with hypoxia, and follow them long term. So sometimes children will not be hypoxic, but they have a pulmonary AVM that's large. Well, those are people that are going to get treated. Maybe they're symptomatic. Those are going to get treated. So maybe they're slow at running on the field and they feel like that's changed a little bit and they're more out of breath than they used to be, and they have a pulmonary AVM, then they're probably going to get treated. This is an example of a child with a large pulmonary AVM. So this would have been caught using that Dutch protocol where we look at the chest x-ray. And you can see here, this is a huge pulmonary AVM, and this patient was hypoxic and had nosebleeds, and we treated it. And this is cool. We did these 3-dimensional holographic images to try to lay down, understand the anatomy. And and then here's the angiogram. Just looking at this patient here, you can see how big, so much blood flow is going to the AVM rather than the rest of the lungs. We actually, to do that, we 3D printed some pictures, the pulmonary AVM. We were able to shape catheters to get into some of these branches that were really challenging. So it was kind of fun. Okay, so the 3 millimeter rule, it applies to children. So we like to treat asymptomatic children with pulmonary AVMs when the feeding artery is 3 millimeters or more, but it really depends on where you measure. So as I mentioned before, you want to measure the feeding artery just right by the sac. But if I measure in certain places, it can be small, it can be below 3, and other places it can be below, above 3. And so it's just basically where you pick to measure. And so there's some wiggle room there. So I want you to know that it's not completely objective. You think it's objective, but exactly where you choose to measure is sort of the subjective part. The next guideline comes from 2009. It refers to adults. And this is embolized pulmonary AVMs with feeding arteries between 2 or 3 millimeters or greater than 2 and 3 millimeters. And that is because patients with feeding arteries greater than 2 millimeters in adults have been identified as having, they have an increased likelihood of having paradoxical events of like stroke or brain abscess. So 2 to 3 millimeters is kind of the threshold in adults to treat pulmonary AVMs, even in asymptomatic patients that have no symptoms. The next is pregnant women with HHT who have not been recently screened and or treated for pulmonary AVMs should have the following done. This was also somewhat, there was a lot of discussion about that. In asymptomatic patients, we should get a bubble echocardiogram. So if you're pregnant and you have no symptoms at all, but you know that you have HHT because you've genetically tested, for example, or you've had the Carousel criteria, then we'll get a bubble test and or potentially get a non-con chest CT. Now, most places, the HHT centers will avoid getting a CT scan on a pregnant patient, so we'll probably go with the bubble test. If you're symptomatic, however, then we go ahead and get the non-contrast chest CT, and that is done in a very particular way, where we want to use a very, very low dose, and we want to do it after organogenesis is formed for the fetus, because we do not want to expose the fetus to radiation unless it's really critical. So we do everything we can to prevent radiation in pregnancy, but sometimes if a patient has a pulmonary AVM and they're symptomatic, then we get concerned because these can rupture during pregnancy, and so we want to potentially treat them even during pregnancy. There's increased maternal risk from pulmonary AVMs in pregnancy, particularly if they're large in untreated patients or unscreened patients. And in one series, there was a risk of major complication or death of, that's pretty high in medicine, about 6%. So we want to avoid all of that, and particularly in patients with large pulmonary AVMs. The other thing is that during pregnancy, because of increased blood flow through the body and hormonal influence of pulmonary AVMs, they can grow. And so we want to make sure they haven't grown out of control because of those physiologic changes and the hormonal influence. So this is an example of a 27-year-old female that had a pulmonary AVM on each side, and I embolized those, and that was fine. The next recommendation is long-term advice to patients with documented pulmonary AVMs if they're treated or untreated. They should get, if you have a PAVM, you should get antibiotic prophylaxis for procedures with the risk of bacteremia. So that really refers to dental cleaning, sometimes, colonoscopy, those kinds of things. When we get our teeth cleaned, little bits of bacteria shower into our bloodstream, and those can potentially go to the brain and cause a brain abscess. Next is to avoid air in the IV when possible, but it does not weigh in on the filter. So those guidelines that we looked at do not weigh in on using an IV air filter. And this is really important because a lot of patients, a lot of HHT centers, say you should use an air filter, but we know that this causes problems in ERs, for example, when people go in and they don't have the filter, and should they get the IV, and are the bubbles a concern? We recommend, if you don't have a filter on hand, and sometimes you can't use a filter, like if you want blood or if you want to use it to get a CAT scan where they push intravenous X-ray dye through your veins, then you should just really make sure that they don't let any bubbles into the vein, into the IV line, and to make a wet-to-wet connection. So they prime a line and they connect it to your IV, but you don't want to see a bubble go in there. We also recommend avoiding scuba diving because there's a theoretical risk of decompression sickness when you use during scuba diving. So those are the guidelines, and I want to stop in the interest of time, but basically the conclusions are for children, we're going to screen all patients with HHT for pulmonary AVMs For children, we're going to use bubbles or pulse ox plus chest x-ray. For adults, we typically use bubbles to screen. The guidelines give us some direction on embolizing pulmonary AVMs. The 2 to 3 millimeter threshold of that feeding artery is what we look at for asymptomatic patients, patients that have no symptoms. But that threshold changes depending on if you have migraines with aura or if you have other symptoms, then we want to help you. And possibly there's wiggle room on the guidelines there to treat. Long-term follow-up is needed due to the risk of persistence. So if you get a pulmonary AVM treated and you're not getting follow-up, then we don't recommend that. We want you to get follow-up because persistence or recurrence of the AVM can definitely happen over time. And then in pregnancy, you should get screened for pulmonary AVMs and recommend embolizing pulmonary AVMs even during pregnancy in the second trimester after organogenesis in the safest way possible for the fetus. And we advise pulmonary AVMs patients to get antibiotics, not let any air in their IVs, and avoid scuba diving. And that's all I have to say today. Thank you so much for your attention. Appreciate it. Now, take it on to Susie.
Great. Thank you, Miles. That was really, really helpful. A lot of great information. So while Susie brings up her screen, why don't we launch our third poll? And it's asking, do you know that migraines can be associated with pulmonary AVMs?
I want to answer it because, but yes, they can. And I don't want to screw the poll up. But yes, they can. Migraines with aura can be associated with pulmonary AVMs. The migraines with aura are more common in patients with pulmonary AVMs than patients without pulmonary AVMs. And actually treating pulmonary AVMs can improve patients' migraines. And sometimes people with migraines that have treated AVMs can say, I think my pulmonary AVM might be back because all of a sudden my migraines are back.
Great, thank you. So Susie, would you like to share a little bit about your story?
Hi, I'm glad to be here. I was formally diagnosed with HHT back in 2005 after my grandson was diagnosed. We were not aware that we thought what we had was just nosebleeds, and come to find out it was a whole lot more than that. And I had screening at a non-center of excellence because my insurance wouldn't pay for me to go to WashU at the time, and had some AVMs embolized. And then referring back to my medical history, 15 years prior to that, I had had a very large PAVM embolized based on an x-ray that a surgeon had done. And prior to that embolization, I had debilitating migraines to where I would be in bed for 2 or 3 days or wind up in an ER and get a shot so I could just get rid of the migraines. And following that first embolization, my migraines improved greatly. They didn't go away, but they improved. And then I had 2 more done after my formal diagnosis and still had migraines. And I knew HHT patients were at more of a risk for migraines. But in my brain, I figured, well, it has to be people with brain AVMs. It wasn't pulmonary AVMs. So it was really eye-opening to realize that, okay, I have to be more aware and make sure that I get my screenings and everything. And in April, I went to see Dr. Meeks in Little Rock and for my screening, and we were discussing it. And I told her that I was still having migraines, approximately 1 to 2 a month. And following my non-contrast CT and that, we discussed going ahead and treating my 2 AVMs that she had seen that might be causing the problems. We went ahead with the embolizations, and I am more than 1 month out and have not had a migraine since those embolizations. And that's the longest I've gone without a migraine in my adult life. And so I feel very fortunate and hoping that it doesn't come back. But we'll continue on with my screenings and, just keep being aware.
Great. Well, thank you so much. I really appreciate all of our presenters and the information they provided this evening. And so I'd ask Dr. Conrad and Dr. Meek to join us with their video. And we will move into the Q&A. And, this was scheduled to end at 8 o'clock. Obviously, there's a lot of very important information that we wanted to share with you all. So we will go beyond that time to answer as many questions as we can, because I know there are quite a few out there. So let's start with the first one from Joel this evening. He asks, can you have too many lung AVM embolizations? And both Mollie and Miles, you are muted.
Go for it, Mollie.
I would just say it's a balance. And that's part of why I would highly recommend people go to a center of excellence, because when we do an embolization, you are going to get radiation. And so with every procedure, you're getting radiation and you're getting contrast. And it's really a balance between how big your AVMs are and how many you have. Certainly some pressure measurements in your heart can change too, depending on how many you do. But there's not like a hard and fast 10 is too many or 15 is too many. It's very patient specific and patient dependent. But I would say that is a reason to go to a center, because the faster and cleaner it gets done, the less radiation you have.
Great, thank you. So Madeline has asked, how often do you need to get a bubble echo if you have small PAVMs that don't require intervention?
Yeah, that was kind of addressing the guidelines. So typically every 5 years in adults is, if you have a less than a grade 1 bubble echo, let's say you have a few bubbles go across, or you have a CT scan that shows that you don't have significant, large enough pulmonary AVMs that need treatment, then many times we'll try to watch you with bubble echo so that we avoid repeating CT scans every 5 years. But typically the interval is every 5 years, depending on your situation. There's sometimes, if we're worried that an AVM is kind of grown a little bit and we want to watch it a little closer, then we may deviate and go to every 3 years. But the whole goal in the field of monitoring AVMs in radiology, as Mollie and I know, is to always try to use the lowest possible dose of radiation. So we'll stretch it out as long as we can, and we get kind of sensitive when somebody's had a lot of CT scans.
Okay, fantastic. So Ed has asked, and you kind of mentioned in your talk that you need prophylactic antibiotics when you go to a dentist if you have known PAVMs, either treated or untreated. But he's asking, should every HHT patient, like if you don't know if you have lung AVMs, also be doing prophylactic antibiotics?
I tell people yes, because the risk of the antibiotics that we give are very low. Now, certainly people can have a allergic reaction to an antibiotic, but that's very rare. But once you've been screened, and if you really screen negative, like if you have a completely negative echo bubble, then I do say people can, give up on the antibiotics for a while until we do a rescreen. But especially in families where we're just starting to get everybody worked up, I just say everybody gets antibiotics until we get it figured out, and then we can sort through the pieces.
Fantastic, great advice. And along those lines, I know you touched on dental procedures and colonoscopy, but Cheryl is asking if there are other examples of dirty procedures that they should be taking antibiotics for beforehand.
Well, most of the, so if you had a, you know, a long bone fracture or something like that, and you get, you know, a intramedullary nail and they have to fix your femur, for example, or something like that, then those patients are often getting peri-operative antibiotics anyway. So big procedures in hospitals, you're typically getting intravenous antibiotics. Other dirty procedures, I think besides colonoscopy and dental cleaning, those are the big ones. I can't think of anything else that isn't really surgery. That's not a, that's,
We get asked a lot about tattoos. Does that fall in
oh,
that category?
that's a great question. I've never thought about that. I don't think so. I don't know. Molly, do you have any thoughts on that?
That's a great question. I've never had anybody ask me that.
You can clean the skin pretty well. You know what I mean?
Yeah, I mean, it's pretty clean and the needles should be clean. So I wouldn't worry too much about that.
Well, I guess if you're using dirty needles, then you should probably take antibiotics. That's the key.
That sounds like a good plan.
If you're sharing needles, yeah.
So James is asking, how often do treated PAVMs reopen?
I tell people maybe 1 out of 4 times if you watch them long enough. You know, so some people never, and other people it's like every single thing. It's I'm sure there's genetic pieces to it that are specific to the patient, but I in general tell people 1 out of every 4-ish times. Miles, what do you tell people?
Yeah, just about that. I think it's really interesting to me. You know, pulmonary AVMs, they just tend to recur. It's kind of impressive in children. They recur sometimes. There's been some studies that show they recur at a higher rate than adults. The biggest cause of recurrence of a pulmonary AVM is the artery that you embolized just regrows through the old coils or the plug that was put there to begin with. And that's one of the reasons that, you know, HHT centers, people like, you would want to go to somebody like Mollie, because what Mollie would do is she wouldn't just put 1 or 2 coils in there. I mean, she would pack that feeding artery tight with a lot of different coils, or maybe use plugs that would really, you really want to do everything in your power to prevent that future growth through the coil pack. And so those are some of the techniques that we've learned over the years. Sometimes pulmonary AVMs that are treated in the community, they won't put enough coils in the feeding artery, and so recurrence is a little bit higher. So yeah, we're obsessed with preventing recurrence, but still it happens.
And Susie, I would ask, you know, what has your experience been with the embolization procedure itself?
As far as
just, you know, a lot of people, there's just for anyone who hasn't had one, which I believe in our pool was a pretty good number of people, just don't really know what to expect from that. And so from a patient perspective, you know, how did you feel going into it, coming out of it, etc.?
Yeah, it's a lot easier than I first expected it was going to be. The prep's not hard. It's like a normal day surgery type deal. And you really, I mean, you're awake and you're aware because you have to cooperate, but I don't remember all of it. So it's like you're there, but you're not there. And then afterwards you recover, and then you get to go home and take it easy for a day or two. It really is not bad. It's very easy. My husband was very overprotective, and he says, well, okay, you did that pretty good.
Well, great. Well, thank you for sharing that. So Ed is asking, what are the risk factors for embolizing PAVM?
So I tell people that the risks of doing the procedure are almost the same as the risks of the way it is with you just walking around. So, I mean, I can cause a stroke when I do the procedure. I can tickle your heart when I move the catheters and wires through and give you a funny heartbeat. You know, I'm going to run those tubes through your veins so you could get a blood clot around the veins. In theory, we could rupture one. I mean, but those are sort of the same risks that you have just going about your daily activities. And the more of these you do, the easier it is to do them, which is, again, you should go to a center if you can.
The next question is asking just for a little bit further explanation about what is an aura relating to a migraine, and asking if it's the same as what's called an ophthalmolic migraine. So if you could just expand on that a little, and maybe Susie, you could share, because I think you've experienced these, you know, what that's like for you. So Dr. Conrad, do you want to start first?
Sure. Yeah, sure. So a migraine with an aura is also called a classic migraine, which is basically you have a, you know that the migraine is going to happen because you have a flickering light or something like that, some visual cue that tells you you're about to get a migraine. Now, this is the ophthalmic migraines. I actually get those periodically, and I don't have any headaches at all. And a lot of people have that. And so you have some kind of flickering thing. So yes, we're talking about the light change, or the weird feeling, something that tells you you're going to have a migraine. And I think Susie had migraines with aura, so maybe nobody better to describe that than what it's like to have it as a patient.
Yeah, the auras are always my first hint that this is where I'm headed. And it is, it's literally a flickering of like lights and things like that. And typically I sometimes will also start getting nausea at the same point with the auras. And it's, you know, if I get the right medicine on board early enough, I can kind of stop the migraine. But if not, that aura, the lights, that's what's going to typically let me know that I'm headed toward migraine.
Okay, thank you. So Chris is asking if age affects PAVMs. Do they form as you get older? Do you get more as you get older? Is there any impact there?
Certainly, you're more likely to have them the older you get. We think that there are some specific things, like some of the growth hormones involved in puberty and involved in pregnancy, that make them grow more. And we are hoping, and Miles can talk a little bit more about this, but we are sort of hoping that as we continue to follow people with echo bubble, we will discover maybe that if you get to a certain point, like maybe if you're 50 and you have a stone cold negative echo bubble, then maybe we don't have to follow you anymore, or maybe we can wait 10 years to follow you. And so I think there is something about they sort of grow during puberty and early adulthood, and then they can recur and they can grow more. But we are hopeful that if you are negative at a certain point, that we can call you negative and sort of leave you alone. We're not quite there, but we're getting close, I think.
Okay, great. Well, Tamara says that she has an 8mm PAVM and has some electric surge-like feelings in the center of her chest, and is asking if that would be linked to a pulmonary AVM.
Oh, I was going to say, well, the first thing is the 8mm part doesn't necessarily, I guess I'd have to ask if that refers to the sac or the feeding artery, because a lot of times when the chest radiologists measure a pulmonary AVM, they measure that sac. But what we're really interested in determining whether there's a risk of stroke or something like that, it's really that feeding artery. But as far as atypical chest pain, yeah, that can be related to a pulmonary AVM. The dreaded concern, of course, is that people have chest pain because little clots are going into their coronary arteries, the arteries that supply the heart, and cause transient episodes of chest pain. But certainly people can have, you know, chest pain related to a pulmonary AVM. It depends on where it is, but typically if it's really up against the lung surface, those are the ones that are a little bit higher risk for rupturing or something like that. So yeah, they can manifest that way, but usually they don't cause pain. Usually they're just, you don't know you have a pulmonary AVM at all. And usually they're going to be manifested with other things like shortness of breath or TIAs or mini strokes and things like that.
Okay, great. So our next question comes from Kathleen, and she's asking, what is the difference between plugs and coils?
Good one for Mollie.
So there are a billion different things that we can put in the vessels to plug them up. So coils look like little slinkies. And there are different shapes of plugs. We have plugs that look like little Hershey Kisses. We have plugs that look like wind socks. And every day there's a new plug. I got an email last week, there's a new plug coming. And so it's like there's a new this, new that. There's always new things. And actually, you know, in the old days, they used little balloons. And then if you get a really big one, sometimes you can strip a wire and put an actual piece of wire. I mean, there's all kinds of things you can put in to plug up the artery. The point is you got to get it really plugged up and really packed in there tightly, or get a really nice, some of the Miles and I both, I think, love a certain kind of plug. But that's, you know, temporary until a new certain kind of plug supersedes it. So there's a billion choices depending on size, location, all different kinds of things.
Well, the cool thing is that, you know, all these pulmonary AVMs used to be managed until like the early 90s by surgery. If you had a big pulmonary AVM, you would get, you know, a lobe of your lung resected, or someone would try to cut out a chunk of lung and remove it. And all these plugs and coils and all this stuff have really been, have exploded in the last 20 years. Due to different new metals and different fabrics and all these things. So it's kind of fun for Mollie and I because, you know, we like gadgets, and all these little endovascular, small little tiny little devices are just exploding on the market, and we get to try them out, and it's kind of interesting. I think the key point though is that we are really careful about what we use, and we want to make sure they don't migrate through the pulmonary AVM while we're treating it, because that's bad. Like if the coil slipped through the pulmonary AVM and went into a vein, then it could go into places that could cause complications. And then also, like Mollie was saying, you got to really treat these well with as much tight packing as you can. If it's a coil, and if it's a plug, you should, you know, use the right kind of plug.
Okay. And Lucas asked, can a coil ever come loose, and what happens if it does? So does that kind of relate to if it's too small and it passes through, or could they become loose even if they're put into place properly?
So in general, if it doesn't come loose during the procedure, it's not going to come loose. It technically can come loose during the procedure, which is why we have devices that unscrew, and we measure sizes, and we have big coils and little coils and funny shaped coils and tornado shaped coils and all these crazy things. But it can certainly come loose and whiz through the system during the procedure. That is very, very, very rare, and doesn't generally happen after the procedure's over.
Okay. Kathleen has asked, what is the oxygen saturation that's acceptable for an HHT patient?
You know, that's a tricky question, because there are many patients out there with many different PAVMs. So they have a lot of little ones all over. I shouldn't say many. There are a few patients out there, at least in our system at UCSF, that have tiny little AVMs in different parts of their lung, and anywhere you look, you'll find a pulmonary AVM. There are some patients that have you know, a few AVMs. And so what we ideally, if somebody is hypoxic and they have pulmonary AVMs, you want to be able to treat them with a catheter, like the little tubes that we go up and plug them up, and treat them as much as you can without hurting the rest of the lungs too much. And so there's kind of a trade-off. And some people are on oxygen. Typically, like if you're below 90%, then you might be on oxygen. And there's certainly long-term side effects to long-term problems if you're not on oxygen and you need to be on oxygen. For example, pulmonary hypertension and things like that, where the elevation of the artery in your lung artery, the elevation of the pressure in your lung arteries can go up and things like that. So there's a balance there, but there's no strict cutoff. I mean, you know, it kind of depends on what someone is dealing with. If there's no real good alternative to improve their oxygenation with a catheter, then you know, they might need to be on oxygen.
And so Elise is asking, we're saying that she has many small PAVMs and experiences shortness of breath, but her oxygen level is not usually low. It's more normal. So does that mean that she's experiencing shortness of breath from something else?
It certainly could. There's, you know, as many causes of shortness of breath, you know, as there are colors in the rainbow. So I mean, really, like it can be both. It can be a little bit of pulmonary AVM and it can be a little bit of COPD and a little bit of old heart attack scar, or I mean, there are tons and tons of reasons for, or maybe you're out of shape, or yeah, I mean, there are 1,000 reasons to be short of breath, and that's how it gets really tricky in figuring out who needs to be embolized and when. And so it seems really easy. It's kind of like Miles said earlier, these seem like things that should be black or white, 2 millimeters, 3 millimeters, do it, don't do it, but it's much fuzzier than that, sadly.
Well, yeah, you know, interestingly, I mean, the guidelines were, you have to get, I can't remember how many physicians were there and patients and family members, but you have to get everybody, there's consensus. In order to develop consensus, sometimes you can't be really granular. You have to kind of make it a little bit broad. And so the expense of that, of course, is that sometimes it's hard to apply the guidelines to a specific situation. And they're just sort of broad guidelines intentionally, because that's how we developed consensus.
Okay. So what are the risks of an MRI to someone that has pulmonary coils?
Well, that's a really good question. It depends on when the coils were placed. Most modern coils do not have iron in them. They're not steel coils. So the modern coils are made of platinum or nitinol typically. And those are modern metals, or at least nitinol is a synthetic metal alloy that doesn't have ferromagnetic properties. So if you take a magnet to it, it's not going to attract the coil. And so those patients generally just do fine. There's no problem at all. The coil may warm up a little bit, but it doesn't cause any problems. And so many of our patients, you know, in HHT have coils and they have something going on in their brain. Maybe they have a brain AVM. And so those patients are all getting MRIs and there's just no problem whatsoever. But in the old days, they used to use coils that were steel and they were ferromagnetic, meaning that they are attracted to the magnet, and those patients might get pain or would have potentially a complication and they cannot get MRIs. Depending on the
are
situation.
patients made aware of the kind of coil they have, or is there a particular timeline when that changed?
Well, steel coils, the GN Turco steel coil was one of the ones that was used for a number of years. I don't know, Molly, do you know when those went? I mean, they're still around, but I don't think they're being put in people's lungs anymore.
Because I'm sure there are some older HHT patients that were coiled many, many years ago and maybe still getting coils. So they might have a mix of both. I'm just wondering if there's if they would be told the type of coil that they have, if that's in their medical record. And, two, if that's not possible, is it just more or less a timing, like, prior to 1992, kind of thing?
Yeah, I don't know the answer exactly. Do you know, Molly? Like,
So there's not, I mean, you're not going to have a firm cutoff with the dates but the early 90s, certainly they were around. I think after the 2000s, most things will be newer stuff. You can ask the doctor what kind of coil you had, if you can find them, like it just popped up in the chat. Worst case scenario, you cannot get an MRI and you can get a CTA of your brain, which is not as perfect, but is spectacular and works great. So, there are other solutions to taking pictures of people's brains and things if you really are concerned, but most of the stuff after 2000 is going to be MRI compatible.
Okay. And we're just going to ask a couple more questions. Have you noticed that individuals receiving Avastin, are their lung AVMs shrinking or disappearing?
well, that's a wonderful question. And that's something that we really need to investigate, whether anti-angiogenic therapy can be used to treat pulmonary AVMs, particularly ones that are diffuse. So if someone has pulmonary AVMs all over their lungs, you may not be able to fix all that with a catheter where you go in and plug it up. And those are ones that potentially could benefit from Avastin. And there's no really, or bevacizumab, which is the generic name, or some of the other anti-angiogenic medications like pazopanib. So we don't know. I have personally not seen any change, on the CAT scans or the angiograms, but people do have some benefit. Some patients, I have one patient that has, it was intermittently coughing up a little bit of blood, and the Avastin would help diminish those, decrease the size of the arteries. Theoretically, we think, we didn't see that, but decrease the size of the arteries so that they wouldn't cough up blood as much. But the expense was that it caused a little bit of chest pain. So I think it has to be investigated, and it's a pretty exciting thing. The idea that an anti-angiogenic therapy can be used in the lung, it just hasn't been studied well.
Okay. And these two are sort of related. One being, does living in high altitudes impact anyone with a lung AVM or cause them problems? And also vigorous or intensive exercise after you've had an embolization?
So certainly the high altitude could impact, if you have big pulmonary AVMs, you might notice a difference when you change altitudes. It certainly can impact your hemoglobin and how many red blood cells you have and things like that. So all of that can contribute to symptoms, shortness of breath and things related to your pulmonary AVM. And then the second question was?
Exercise, like does vigorous exercise after embolization, is that okay? Or does it impact?
So I tell my patients absolutely. And sort of the better your baseline status is, the less impact the pulmonary AVM is going to have. So the same size pulmonary AVM in somebody with lots of other heart problems is going to have more impact than in somebody that's like a marathon runner, if they're exactly the same pulmonary AVM. It's just, there's lots of pieces that can give you headaches or make you short of breath, and all of them together. But so exercise is great. I encourage exercise.
I'm a little bit, I'm okay with people running and doing, cardio. It gets me a little nervous when people are doing, if somebody was to join like a gym and start doing big time maneuvers to try to exert a lot of force, like the Valsalva maneuver, which is when we bear down when we're lifting big weights and stuff. And one time I had a trumpet player, and I was a little concerned about, the energy that he was exerting. I mean, that's a lot of energy in your chest. And so we were talking about that delayed migration risk, but yeah, so I don't know. I just get a little nervous about that, but I agree with Mollie regarding everything else that, you know, exercise in general is great. It's just that one part that's gets me a little nervous sometimes.
All right, well, I know we've had a lot of other questions to ask, but we're just going to close with this one. And really, it's asking, how can someone persuade their local pulmonologist to use the guidelines? And do HHT doctors consult with local physicians, especially if, you know, you've been to the center? So would you both want to speak to that? And I think Susie can speak to that as well, since she's had both situations.
Well, I can just start by saying that pulmonologists are some of the smartest doctors in the hospital, and they are known to be very evidence-based. So hopefully your pulmonologist is going to use evidence to make medical decisions, and they want to use the latest and greatest evidence available. And the guidelines really are supported in evidence and consensus, and they're published in a very prestigious journal that they would read, the Annals of Internal Medicine. And so I would hope that your pulmonologist would take a look at those guidelines and understand that those are the best. That's the best evidence we could come up with. And then in terms of helping people in the community, we co-manage, you know, we co-manage with pulmonologists and cardiologists and hematologists all over California and in some places like in the Western US. And it's just the norm of HHT centers because people come, like Susie came from far away to go to Mollie, and Mollie, I don't want to speak for Mollie and Susie, but, you know, basically we have to be involved in management in faraway places.
And one of the benefits of COVID, one of the few benefits of COVID, is that telemedicine is, you know, insurance has picked up coverage for telemedicine, and we're allowed and we get reimbursed now to do more telemedicine visits. And so I think that that is actually one good thing that's happened from COVID that people can take advantage of for sure. And Susie has been to all different kinds of doctors all over the country. So she can tell, and she's had insurance problems too. So she can tell you about all.
Yes, initially my insurance would not cover me to go to a center of excellence. And I was very fortunate that at that time I was in the Kansas City area, and WashU worked with all the doctors there that I was dealing with and helped me get the care that I needed to get. And I've moved again, and now I'm in Louisiana and picked University of Arkansas Med Center up there to continue my care here. And I've had nothing but positive between working with non-HHT doctors and the Center of Excellence. They've all been wonderful.
Well, that's fantastic. Well, again, I just appreciate all of your time tonight. I know we have gone over by a half hour, but I think it was really great questions, and I appreciate all the responses. And so just on behalf of everyone at Cure HHT, I want to thank you for attending tonight's webinar and for staying connected with us. Cure HHT is the only patient advocacy organization funding HHT research, providing education materials to patients and providers, advocating for the disease, and expanding treatment centers around the world. So just remember that we are here for you, and feel free to reach out to us at any time. So we're just so grateful for tonight's speakers and for the McMahon family's commitment to pay it forward so that future generations have a more effective treatments and ultimately a cure for HHT, because without their financial support, these guidelines would not have been possible. So I just want to remind you that if you haven't received your complimentary copy of the Comprehensive Guide to Managing Your HHT, please let us know by completing this short survey that will pop up on your screen at the end of this webinar. This is only one topic in the guidelines education series, so we will cover every topic separately, and you can register for all of those webinars on our website at www.curehht.org. And lastly, I want to remind everyone that June is just around the corner. It is next Tuesday, and that is the beginning of HHT Awareness Month and the Foundation's 30th anniversary. And there will be a ton of events and activities all month long, from a virtual walk called the Strides for Strength, which is June 5th through the 20th, more guideline webinars, and the Cure HHT 30th anniversary celebration will be on our Global Awareness Day of June 23rd. So keep visiting our website, check social media channels for updates, and open those emails that come across your inbox for updates on these and many more activities. Again, I just want to thank Dr. Conrad, Dr. Meek, and Susie Sayers for volunteering their time tonight. This program has been recorded and will be posted on our website. We truly appreciate everyone's participation, and I hope that you enjoy the rest of your evening. Good night.